Hi, everyone. We're going to go ahead and get started. We'd like to welcome you to today's Lunch and Learn Financial Stability Primer for Practice Managers Part 2. This is a continuation of last week's Part 1. This webinar is part of the North Carolina AHEC Practice Support Services Lunch and Learn webinar series. Just a quick reminder, please mute yourselves. There'll be designated times during and after today's webinar for questions and comments. If you could please put your name and your practice in the chat, we'd love to see where everyone is coming from. And for now, we'll hand it off to Mark and Ramin.
All right, thanks, Danielle. Good afternoon, everyone. Welcome back to those that were here last week for part 1. Welcome to anyone who's new for this session. Again, I'm Mark Holmstrom. I'm a practice consultant and practice support coach at Mountain AHEC. My partner today, Ramin Sadigian, is also practice consultant and coach at MAHEC. We failed to give a little bit of background. I'm not going to give you much, but I've been in healthcare for over 25 years, working in both hospital health system management, operations and planning, as well as practice management. Ramin has been in practice management many years, as well as performing a lot of business consulting as well. So that's just a little bit about ourselves. And let's just kind of jump right in. So if you were here last week, we touched on kind of foundations of sustainability regarding planning, budgeting, and financial reports, and how those can help you prepare for the future, as well as monitoring your current performance. Today, we're gonna dive into more application of certain concepts. We've added a 4th section to go a little bit more in depth into KPIs, or key performance indicators, and then we'll touch on effective payer management, revenue cycle management, and financial modeling. So go ahead, next slide, Ramin. So as we think about key performance indicators, they really are, critical measurements of your progress toward a stated goal or intended result, and should be used again for strategic and operational improvement and decision making, and helping you focus on what matters most to you. Peter Drucker, who is credited somewhat as the inventor of modern management, kind of came up with the term, what gets measured gets managed. And that's kind of the idea of KPIs, is measuring things that you want to drive change on or improvement on. So there are a number of different categories that you can develop KPIs for. These are some of the more common: operations, finance, revenue cycle, experience, and quality. And we want to give you just a couple examples of each. When you choose KPIs, it really is based on what your strategy is, what you want to focus on, what you want to accomplish. So you can choose, a few to focus on. Bigger organizations might have more. So it's really is tailored specifically towards each practice need and what you really want to focus on. So in terms of operational KPIs, some of the things that you might track, patient wait time, success and timing for closing referral loops, staff to patient ratio, things that drive your operations and things that you want to measure and monitor and improve on. Finance KPIs, we mentioned some of these last time, or Ramin did in his section, but these are items that you want to monitor to see how you are doing financially and to drive financial improvement and financial performance. Things like average revenue per visit, staff expense per visit, operating cost, and overhead per visit. Again, things that drive your financial strategy and data monitoring. Revenue cycle KPIs, Ramin's going to get into more detail in his section, so I won't spend much time on those, but there's some specific things and standard measures that that really will tell you how well you're doing in terms of your revenue cycle process. Patient experience KPIs, overall satisfaction rate. Many patient satisfaction surveys will ask about access or communications, response time. So anything that you really want to know about how well you're serving your patient's needs can be a patient experience KPI. And then the final section, I think, is quality. We are really in the business of providing great quality care, and each practice should choose some quality KPIs that really are meaningful to you and your patients in terms of measuring outcomes and how well you are really serving your patients' healthcare needs. You may want to choose specific KPIs related to any value-based incentives that you have, just to monitor how well you're doing and how you may get some return for those. These are examples that are very much primary care related. Specialists will have their own types of quality measures related to their specific service and what they're providing for their patients. But choose quality metrics and KPIs that really you want to drive good outcomes with. So that's a kind of quick summary of KPIs. What we suggest is that you really, again, look at specific KPIs that are going to drive your strategy and goals. Those that are easy to generate, those that your EHR may have reports for already. Use the KPIs to look for change and variance. If you have a particular goal, if you're decreasing in performance, that's going to show you what you might need to improve on. And again, use these KPIs for ongoing strategic planning. Most of the time we think of KPIs as more long-term and kind of monitoring over the long term, but you can also use them for short-term process improvement to really look at kind of a baseline perspective, and then do some change or modification to your process and measure it after that change to see if you've made improvements. So they don't have to just be a long-term perspective. You can use them for some short-term goals as well, and using them to measure your effectiveness in terms of some type of change or quality improvement. So that's just a quick intro and summary of KPIs and how they might be used. Again, we really look at them as more internal measurements that should be used to drive your strategy. I know a lot of times we get questions about national benchmarks, what benchmarks are out there. And in one sense, benchmarks are good to kind of see where you are in terms of your peers. But again, I think that's secondary to using them to actually drive your performance in your practice, monitoring over time how well you're doing on certain metrics. So any questions related to KPIs? Again, we're going to do the same thing we did last time. After each section, pause for some questions if you have any.
We don't have any in the chat. Feel free to unmute yourselves if you have a question, or if you're more comfortable just typing it in the chat.
Okay, and we can certainly come back if you think of something as we're going along. We can certainly come back to address this section as well. So, all right. So our next section is regarding effective payer management and how to maximize your contracts and think about value-based payment. So when I think of payer management, my first thought goes to understanding the different types of contracts and payment arrangements that you might have. And I think about it on a continuum basis, from straight fee for service where you're just getting paid, per unit of service, all the way to potential global capitation contracts in which you're getting paid for caring for a specific population. So most payers and most practices are somewhere in between those two ends of the spectrum as we move through kind of that continuum on towards more payment for populations. So it's important to really kind of understand the variety of contracts you might have, and understand what is entailed in each one of those contracts. And to do that, you really have to honestly look at the details of your contracts. The scope of services, what's included. Is it just professional fees, or the lab imaging included? Other specific service arrangements that might be carved out in a particular contract. So really understanding the scope of services and requirements of your practice, and then understanding how you're going to get paid. What type of reimbursement is there? Again, is it just a fee schedule, fee for service? Is the payment term based on some type of index, meaning you get paid an X percentage of the Medicare rates? So understanding exactly how you're going to get paid will help you understand how to manage that particular payer. Understanding if there's any quality incentives built into the contract is important. So you know what the payer is going to be measuring, and that may be a good idea of what to put on your KPI list in terms of what are you going to be measured against? What might you get some incentive for? Those might be what you want to measure and monitor. Knowing the term certainly is important. Is it a 1 year, 3 year, 5 year, whatever it is? And then what the contract type is in terms of any type of automatic renewal process, or is it a fixed term? That'll help you understand when you might need to renew or renegotiate if possible. And then finally, understanding, the termination clause that is in that contract. Again, so you don't miss a particular time frame. If there's a contract that you're not happy with, or a contract that you want to renegotiate, sometimes you might have to, to terminate the contract in terms to be able to renegotiate. So those are the main things to really understand. Next slide, Ramin. What I used to do when I was in practice management is just have a simple spreadsheet that laid out all these different pieces, so I could monitor it and know kind of where I am in terms of, again, the term of the contract, what's coming up in terms of renewal, how I'm getting paid, and that kind of thing. So my spreadsheet was pretty simple, but it served my purpose. So, and that's just a way to monitor and manage your contracts going forward. Next slide. Yeah, value-based payment. Again, this is becoming more common, and many contracts have some type of incentive process or value-based payment arrangement. This is a particular definition from the Oregon Health Authority. Value-based payment really are payments that will create accountability around cost and quality of care in the context of what the provider can control in terms of coordination and delivering care. And I think that's an important piece to really understand, especially as you may be negotiating these value-based contracts, is to make sure that the incentives and things you're going to be held to really are things that your particular group or your providers can control. You don't really want something in there that you can't affect change on. So I think that's kind of an important piece to really think about as you're moving into value-based payments and arrangements. Next slide. Another good thing to understand is how contracts might progress from a very basic, more pay for performance, fee for service, up to a full risk potential contract. So this is a slide that just kind of stair steps up from with some examples along the continuum of different types of value-based payment arrangements. Many of you will remember the Blue Cross BQPP program. I would say that was kind of an initial pay for performance value-based contract where it was really fee for service, but then had some incentives based on quality and other criteria where you could earn some additional funds. Many of you are in a Medicare shared savings program. The first step is shared savings with only upside risk, meaning you can earn incentives based on your outcomes and measures, but you're not at risk of losing any in terms of that arrangement. So that's kind of the first step of a shared savings program. That jumps up at some point into a shared risk arrangement. Regarding Medicare, there's the level C, D, E, and F of the shared savings program. That's where it builds in both upside opportunity and downside risk based on performance. So now you're really getting into a more of a shared savings, really dynamic, where we're focusing on KPIs that will drive your improvement to make sure you're not hit with that downside risk or loss. And then the final step is really first, full risk type arrangements. There are some models out there that Medicare Innovations has put into place, such as the ESRD treatment choices model, primary care first, which honestly is going through some discussion now whether that's going to remain, but it's a current model which basically allows practices to take a bundled payment or a payment for a population and decide the best way to use that to drive the outcomes. So it's important to really understand where certain contracts are in this continuum, so you really understand your level of risk, upside and downside, as you go through your contract renewals and negotiations. The next slide is very busy. It is a publication from Medicare, which shows the different types of shared savings programs. Again, kind of similar idea in terms of the progression from no risk to high risk and complete risk. So in the slides, if you're able to download those, the link is there if this is something you want to look at. But again, it'll help you understand the different types of risk arrangements and the glide path forward to more risk. So something, again, just to be aware of and understand with your contracts. All right, next slide. So how do you earn incentives when they're built into your contracts? The first is to know what they are and to monitor what you're being measured on. So creating some type of dashboard with your specific measures that you need to monitor and make it rewarded on is important, and reviewing those continually. And I would say at least monthly is a good idea. Again, monitoring those will tell you what you need to improve on and what you need to do to achieve those incentives. So reviewing the measures is important. Again, utilizing that data to identify QI projects that you need to work on, and using the data to understand and fill gaps where you may need to identify specific patients, for example, who haven't had their annual wellness visit yet, or who haven't had diabetic testing. So utilizing that information to fill those gaps to earn those incentives is important. And then incorporating those measures is important into both internal reviews and QI team meetings, so the whole organization is familiar with what you're being measured on. The whole organization can work together on improving those particular measures to earn the incentives. And then when you're good at something, tell the payers about it. And that's where that external idea comes in. You know, if you're really good at what you do, use that to your advantage in your contract negotiations, and trying to drive those value-based opportunities to maximize and get rewarded for what you do well. So measure things, use it to improve, use it to your advantage when you're negotiating contracts. All right, next slide. So here, this is something we did last time, is just kind of give you some questions to ask yourself or your group in terms of effective payer management and how you're handling contracts. So, you know, do you have a list of your contracts? Do you manage them? Do you look at it often? What kind of value-based contracts do you have? Are they direct contract with payers, or are they through an ACO, and how might that impact your measurement and your outcomes and your payment for incentives? Do you actually use the measures that are in those contracts to determine quality improvement projects? And then the last question is always interesting. Have you actually already received any incentive payments? How well are you leveraging your contracts to receive payments? So a lot of things to reflect on and think about as you develop a strategy for value-based payments and going forward. So we'll pause there, and any particular questions related to contract management or payer management?
We have one question in the chat. Sorry, Ramin.
You got it. It was a good question in the chat. Yeah, I think it was referring to this slide. Mark, we got someone asking, what would cause a practice to kind of move from this A/B level to, C, D, E, and F level?
Well, I think there's two. One would be if you're in a particular ACO, they are time limited in terms of how long they can stay in a upside risk only arrangement. So it may be, honestly, it may be forced where your ACO is actually moving to the next level. The other reason would be back to the quality outcomes. If you know you're good at something and all your quality measures are really good, generally when there's downside risk, then the upside gets bigger as well, right? So if you know you're good at what you do and feel confident about being on that upside side of things, then you may be ready to take that risk. It's really something to monitor internally in terms of where you are and whether you're ready to take downside risk to get potentially more upside.
Thanks for clarifying, Mark. That was great. Anyone else want to put some questions in the chat or voice them aloud here before we move on to RCM? All right, well, I'm going to go for it, and we'll have more opportunities for questions. Mark, I appreciate you going through the KPIs and that value-based care, the contracting and all. It's a critical component of practice finances and the future of care. And so I want to get into some nuts and bolts here. Revenue cycle management. Here we are talking about practice finances, and this is obviously a critical part of that. And we want to get into the nuts and bolts of revenue cycle management. And I kind of made this diagram to identify all the parts of the practice that influence revenue cycle management. All these components have an impact on your revenue cycle management performance. And I just want to take a moment and acknowledge that's pretty much most of the practice. And so it's a lot to take on. And also just good to know that all these parts influence the practice. I'm going to go through them one at a time. The routine, right? It starts with scheduling, it ends with payment posting. And as we have our key performance metrics and we're trying to improve our revenue cycle management, we want to identify different parts of the process and focus our improvement on them so we can have better practice finances. So I'm going to go through this one at a time. This is the circle of life of RCM. And so it starts with scheduling. right? Ways this influences revenue cycle management. We want to make sure we have the right demographics, the phone number, the address, the correct insurance information, lots of improvement opportunities there, scripts, those type of things for staff. Taking the next level, front desk. There is a lot going on in the front desk and a lot of opportunities to help our staff. Opportunities for improvement here, or we're making sure we're doing our benefits and eligibility check prior to the appointment, taking that another level and making sure we're collecting the patient responsibility at the time of service. And then some foundational stuff as far as just having financial policies in place to support your operations. And merchant services. There's a huge opportunity in merchant services, a lot of ways to integrate that within your EHR and have one report to reconcile instead of multiple third-party reports. A lot of digital technology opportunities in merchant services, from payment on file to text to pay, payment online. It's really worth working at these merchant services and really empowering your staff, again, so we can collect those payments. And so kind of next step in the process is the patient care. The basics of having the appropriate CPT codes and diagnosis codes from the care process, right? We want to complete our notes, ideally the day we provide care. And then I added telehealth, because this has kind of been a game changer with COVID. Right now, we're doing a lot of telehealth, and I want to go back and we're trying to grapple with finding ways of reincorporate the front desk services into the telehealth process. And it's a lot of what we're trying to figure out as practices, but I'm just calling this out as an opportunity. But we have our patient care, right? We want to sign off on notes ideally by the end of the day. And then we want to file those claims ideally within 24 hours from the date of service. And this claim submission process has some parts to it. It's going back to the clearinghouse, right? We have scrubs in place to make sure our claims are scrubbed or cleaned before we send them to an insurance companies. And these scrubs kind of reject or hold claims, and we got to make sure we're following up, correcting those scrubs and submitting the claims. Ideally, we want a clean claim going out to our insurance carriers within 24 hours of the moment of care. And again, just breaking down opportunities for improvement here as we're trying to focus on improving our revenue cycle management process. And the clearinghouse. This is a major technology that's a part of every practice that's kind of in the background. And a lot of opportunity here. A pet peeve of mine, all my practices hear it, and I bring it up on every webinar, is EFT and ERA integration, right? It's done through your clearinghouse. You want all your insurance payments to go direct deposit into your bank account, right? I want to be clear. We don't want to get insurance payments by check. We don't want them to fax us an image of a credit card. All that's got to be integrated, go directly to the bank account. And then same with the payment information, right? We're going to look at our bank account every day and see what deposits were made. And then we want to know how to post those payments. And that information, again, should be integrated through your clearinghouse into your payment practice management system, into your billing system. And it really sets it up to auto post. And what I'm trying to say is I don't want our staff getting EOBs through the mail for sure, or fax. We want to limit staff needing to go to provider portals to chase down these EOBs. All that should be integrated in your through your clearinghouse into your practice management. I went through a lot here, a lot of steps. You have these slides, but as we're going through and trying to identify ways to improve our RCM process, we're doing the things like we've been mentioning a week ago and now with our key performance indicators, looking for variance and seeing which parts of the RCM process we can target here, right? Obviously, we can check in with our staff and see what ideas they have, what complaints they have, same with patient complaints. And you're kind of doing those KPIs and looking for variance and doing your interviews with staff and patients and trying to identify ways to improve your RCM. And I keep saying it, but I really invite you to pick one part of this process at a time, right? Start with your front desk, make sure they have the tools in place so they can influence the RCM in a positive way, go through the merchant services. Then maybe when you're done with that, you want to go to your clearinghouse and make sure all your integration's set up. It'll take a few months to go through each of these steps. Mark mentioned I was a practice manager, 10 years. I ran a derm office, and I would just go through this cycle. It would probably take me all year to go through this cycle. And at the start of the new year, I would just take it from the top and start all over again, making sure people are practicing in a manner that you set up the system and just trying to improve it again. And so a lot to take in here, but just invite you to pick it apart one part at a time. And so KPIs for RCM, Mark went over KPIs, but here are the common ones. Instead of me going through them all, I really recommend referencing this source. American Academy of Family Practice did a great job of going through these and how to calculate that. They made cute videos and they just do a great job. See the source. I'm going to let you do that. They teach it in a way better than I. But for the fun of it, we're going to go over one together. And this is one of the most common key performance indicators for revenue cycle management. And it's a days in AR. And how I try and define days in AR, it's the number of days of operations like revenue you're generating that's caught up in AR. And so we're just going to go how to calculate that. You're going to calculate your daily charges on any given day. And typically the standard is to look over the last 6 months. So in this example, a practice had $280,000 in charges over the last 6 months. And there was 182 days, right, in those 6 months. So that's every day. They're averaging about $1,500 a day in charges. That includes the weekends. And this same practice has 70 grand tied up in AR. So you see how many daily charges fit into that 70 grand, and you have 45 days in AR. And I just want to say that again, in this example, we have 45 days in AR of services that are tied up, waiting to be paid, services that we've delivered. And this is a really important key performance metrics. Healthcare benchmarks are 30 to 40 days in AR is where you want to be. Definitely not in 50 days. But this 45, it's a little high, in my opinion. I'm inviting you to go back to this circle of life and start picking it apart and see if you can improve your days in AR. And going to move on to another kind of chart that's really common to billing departments. Billing staff live by this. I'm just showing you so you're aware and fluent with this report. It's the 30, 60, 90 day accounts receivable report. You break up insurance from patients, right? They're two different animals, insurance AR and patient AR. So you want to separate them. And the reference point is the data service. Right, so 0 to 30 days, this is how much AR we have tied up in the last month of service. Right, 60 days is 2 months out of service, 90 days, 3 months, and so on. And you can see in this example, if you look at the bottom, the 0 to 30 days, most of the AR, and about 90% of it's tied up in 0 to 30 days, insurance AR. You can see similar, different percentages for patient AR. Again, that's a totally different animal. You're running parallel systems, and that's a whole nother webinar. But this is a common chart. Just want you to be familiar with it. And then kind of taking that to another level, we've been talking about KPIs and strategic planning. This is kind of a practice scorecard, right? These are the key performance indicators that you've identified as a practice tied to your strategic plan. And you can put them on here. I like having it on one page. And it's nice to see just at a glance. I like having references. If you look at the bottom of this dashboard or practice at a glance report, it shows averages for last year. So immediately I know what the references are. Ideally, I wish these were goals instead of averages. And that way someone looking at this can kind of see how we're doing again at a glance. And make up your own dashboard. This is just an example. But I really encourage you to have it. And then the next step is, what do you do with all this data, these key performance metrics, right? It's all tied to your strategic plan. You're trying to measure your performance as you're trying to get to where you want to be a couple of years from now, right? We have our financial statements. We have all the revenue cycle management stuff and the key performance indicators there, right? We have a practice snapshot or dashboard or at a glance. I just want you to be thoughtful on who you share this information with. We want to encourage you to share this information with people. That's why we're tracking these numbers, and it's again tied back to the strategic plan. And so I encourage you to share this and just have a plan on whether it's the owners or leaders or department heads. I encourage you to share some of these numbers with staff, like all staff, not the whole practice at a glance, but some. I think there's an opportunity there. You know, obviously your claims department are going to see your claims denials, but I really like front desk collection rate. You know, what percentage of patient receipts are we collecting at the front desk at the time of service? I love sharing that with my front desk staff and folks doing eligibility, number of statements. You get to pick it, but I'm just trying to give you some examples of how you can show specific KPIs with your frontline staff, just encouraging you to do so and have a plan. So some reflection here, just some things to think about for your practice. You know, what KPIs are you tracking and monitoring? Are you doing eligibility checks and really trying to collect at the time of service? Do you have ERAs and EFTs integrated? I'm never going to stop talking about it. It's a pet peeve of mine. I really emphasize that. And how do you handle patient AR? Again, it's a totally different animal. Have a cycle in it for that process. Follow that process you've written out. And then, you know, the basics of monitoring and working denials. This is just foundational billing, right? Combing through all those claims, making sure you're following up in time, right? If they say allow 30 days for processing of appeal, we want to follow up on day 31 and just having that system in place. A lot there, but that's going over revenue cycle management. I'm going to take a little breather here and open it up for some questions.
We have a question in the chat. Why the emphasis on filing a claim within 24 hours of the encounter? Many clinicians are finalizing EMR charting after hours or the next day.
You know, that's a great point. And, you know, it's all a piece of it, you know, and this claim submission cycle time is of a piece of a bigger cycle. And I invite you to focus on one piece at a time. I really like the turnaround time on claims in within 24 hours because it's easy way to impact this KPI, which is my favorite one for revenue cycle management. If we file the claim within 1 day versus 3 days after the date of service, we've immediately lost 2 days in this key performance metrics. I understand it's complicated and a lot goes into reviewing those charts in time, but as part of your process improvement, you know, pick that as one of your projects and try and squeeze that cycle time down and then do it again with another part of the cycle. I hope I did okay answering that question. All right, we're gonna keep rolling here. All right, so we're gonna get into financial models. And this is kind of a culmination of what we've been talking about, from the financial statements to key performance metrics. Right, we got our value-based contracts. We're going to value-based care. So now we want to talk about how to do some financial modeling so we can make sure we can sustain these programs. Right, there's only so much community service we can do. We're trying to get to value-based care. We're going to make some pitches to y'all just for fun to see if we can sustain these programs and help our patients at the same time. So when do we do a financial model? It's kind of anytime you make a business decision, right? I talked about going towards value-based care, even just the basics of setting up another practice or adding another provider or a new service line, right? We want to make sure we know those break-even points. When we're trying to decide whether we're outsourcing something or keeping it in-house, we're doing a cost-benefit analysis and talking about risk. And even support staff, right? If we want to add another medical assistant to our operation or another nurse or another biller, right? Maybe we try and do some math and see if we can measure the return on that investment. And how do we do a financial model? You know, I think it's easy to overcomplicate it, but we're basically making up an income statement. It's an imaginary income statement. We went over this a week ago. Here's the income statement in the background. But basically, you're drafting the income statement in your financial model. You're kind of estimating your revenues. You got your expenses, and you're separating labor from expenses. And you're filling in the numbers for now. Just guess. You'll be surprised. Your guess is pretty close. First, see if you can play with a model and get to a point where you're generating a profit and think you have a sustainable program. And once you've done that, then go back and certainly cross-reference your numbers, making sure they're accurate, even try and get a couple reference points for your key numbers. And beyond the model too, once you feel comfortable that you can sustain a program, assess for risk, like what happens if this fails? And then I call it capacity or the gut check. This is important too. Like, are we ready for this? We're going to add a new service line. We're going to have to follow up and iron out some kinks and troubleshoot some problems. We've got to be ready for that and just kind of do that gut check. And so I'm going to give you a few examples here of financial models. And today's examples are, again, kind of going towards value-based care. You're right. We're trying to tie our modeling back to our strategic plan because it's where we're trying to get 3 years from now. And we'll project some finances. So here's an example strategic plan, right? Say this practice, primary care practice, wants to increase revenues from population health by 30% a year, right? That's their strategic plan. How we get there, they got a multi-year plan, right? We're going to start with building the non-traditional CPT codes. I hope you're already doing things like advanced care planning, transitional care management. Right, then you can launch some pilot programs and improve those processes and expand population health and eventually put a practice right. This is a strategic plan over 4 years, for example. And so we're going to start making some pitches. So here we are as practice managers. We've given this strategic plan that says we got to increase revenue by 30%, and we're going to go about it over a multi-year process. And it's kind of choose your own adventure, right? How do we progress towards plan? We're going to think about our practice. We're going to think about our patient population and how can we serve those highest risk patients between their provider appointments, right? How can we check in on them between their direct patient care to making sure we're helping them out and tying that to our patient population. And then the next step is like, how can we make money doing it? Right, so we can sustain this program, right? Again, there's only so much community service we can do. We need to sustain these programs, ideally maintain some profit margins so we can reinvest this in things like wage increases and additional value-based care investments. So examples that might fit your practice, we're going to go over a couple of them. These are just examples. Adding a behavioral health to primary care is a pretty linear one, and the numbers speak for themselves. Another thing is just having a dedicated population health team, right? Someone that's dedicated to keeping up with your high-risk patients. And then something in between, right? Maybe it's having a nurse work a few half days a week on high-risk patients. And we're going to try and come up with ways to generate revenue to sustain these examples. I'm just going to go over a few of them. So population health nurse, right? Again, we want to grow our strategic plan is to grow our population health finances by 30%. And we're thinking about our practice, and we got a ton of Medicare patients. A lot of them have multiple chronic conditions. So we're thinking of population health nurse as a way to serve this patient population. And so this is our good idea, right? So we're going to project some finances for it. What are the ways we can generate revenue for that nurse, right? First step, I invite you to look at, and I hope you're already doing this, is this transitional care management, right? When people are coming out of the hospital or out of facilities, we want to make sure we're following up with them, getting them in for appointments. Advanced care planning, again, I hope you're doing these, you're billing for these codes right now. There's good money on the table. And then the second step is per member per month payments. And I say this with a tone, because if you can have a financial model that gets paid per member per month, that's fixed revenue that you can really build a model of. And I went to business school. When I hear fixed revenue, I'm excited about that as a financial opportunity. And right now, the model is a lot of chronic care management opportunities. Again, that's mostly for Medicare patients with a lot of high chronic conditions. Principal care management is an opportunity for specialists, right? If you're dealing with a large population that has chronic conditions and you're a specialist, man, I think there's a big opportunity there. And then remote patient monitoring, I won't get into that here. And then you have this third section of value-based pay, right? This vague thing where we're talking about Medicare shared savings payments. And those are hard to calculate, but they are there as revenue opportunities. And I'm also estimating we're going to get some more revenue just in the milieu of keeping tabs with our high-risk patients. They're going to come in more for their annual wellness visits. You're going to generate more E&M visits or like telehealth or labs. You're going to do more gap closures. I think it's going to help provide dividends beyond what this financial model shows. So here we are. These are the revenues. And, you know, I'm trying to be conservative and show you how to build a financial model. So I'm looking at CPT codes. And here's an example of advanced care planning. And right, the CPT code says 30 minutes you can bill for $86. I'm estimating an hour of labor, right? I'm building a cushion into it because I want to be conservative. And you can see we did that down the line, chronic care management, transitional care management. Again, I hope you're doing that. We built in a cushion for labor. And so we started there. And then we were thinking about, you know, what's the typical day of a population health nurse look like? And again, this is a practice that has a lot of Medicare patients, for example. They've identified this as an opportunity to meet their strategic objectives of growing 30% of revenue per year. And so here's day in a life, right? Chronic care management. You've enrolled a ton of your Medicare patients, these high-risk patients, into a program where they know you're going to be checking in with them a few times a month. And I'm picturing this population health nurse kind of going through their list and making sure we're checking in with all those patients every month. I'm estimating they're going to check in with 8 patients on any given day. And ongoing, in addition to that, there's going to be people coming out of the hospital and facilities we want to check in and follow up with. We're going to do some advanced care planning as that opportunity presents. And again, these are just some examples of estimating revenues. And you can see here, if you total up the labor, it's 6 hours of labor. And I've already built in a cushion into the labor. So I'm leaving another 2 hours for meetings and some administrative time. This model suggests a population health nurse with these assumptions can bring in about over $500 a day. And that seems pretty good to me. So let's look at the expenses and see what the costs are. Right, I'm estimating that nurse to cost about 85 grand in total compensation. I'm throwing another half-time equivalent of a support staff. Right, this is a community health worker half-time, or maybe a medical assistant. Right, I want to support that nurse to make sure they can do their job effectively, and I want to extend the value of that license any chance I can. And more on expenses. This is kind of a new program. I'm just throwing in another 10 grand in resources. Right, they're going to need a lot of training, maybe some tech, and I'm just being conservative here because I don't want to go broke doing this program. So here we are tying it together: expenses, revenues. Right, we got about 120 grand in expenses in a year, and I think we can get over $500 a day. And again, I'm being conservative in work days, 225 work days. That's about 46 weeks. Right, so I'm building in 6 weeks vacation, training, other type of projects. This tells me I might break even on this model, and that tells me there's an opportunity here, and I think there's additional revenue to make not only break even but make 10% or maybe a 20% return on this investment, because we're going to get more annual wellness visits. Right, we're going to get more E&Ms. We're going to improve our quality measures just by taking care of our high-risk patients. And get a better Medicare shared savings bonus payment. And some assumptions here, again, this is a high functioning office to take on this program, and that they have the patient population to sustain this program. And this specific investment, we're looking at Medicare patients with a lot of chronic conditions. We think we're a primary care office that has a population to sustain this. And that's just one pitch that's tied to a strategic plan. Think about your practice, your patient population, and how you can build a program to sustain taking care of high-risk patients and make some money doing it. I'm going to show you one more here real quick. Adding a mental health therapist. I love this model because I think the money's there for primary care. Right, what we're seeing is a lot of Medicaid patients need behavioral health, and it's having really trouble finding referrals that'll take Medicaid patients. So it's an opportunity to bring that in-house. And it's basically like adding another provider, right? It's another schedule. You're billing a direct fee for service CPT codes. I really like this business model. I'm putting it under population health, right? Because it's kind of helping the whole patient. And I'm not going to go over this in detail, but this is, you know, if an LCSW can see 4 to 5 patients a day and do one group a week, right? I'm showing we can break even. And again, you can see the numbers here. I'm estimating 80 grand in total compensation. I'm adding a quarter-time full-time equivalent staff, a quarter staff member, right? That's more front desk person checking people in, more scheduling, more billing. I'm throwing in some resources, right? Giving this person some tech to do their job. And I'm also throwing in 5 grand for supervision here, right? If this is our first behavioral health provider, I want to make sure they have some supervision where they can process some cases and just improve themselves as a provider. And again, here it is, 4 to 5 patients a day, 1 group visit a week, and we can break even. My spouse is an LCSW. She sees a lot more than 4 to 5 patients a day in a community setting. I really think there's a good business case for your practices. And this is, again, going to improve your value-based payments, your annual wellness visits. Patients will just be more involved in the practice. And I think even a small practice can add an LCSW and be able to sustain that patient population. So these are a couple of pitches, some self-reflection for you folks. You know, just think about what new services do you plan to offer that are in line with your strategic plan. Let's do some financial modeling to make sure we can sustain those programs. And what are your break-even points, right, for those new service lines? And what's the return on investment calculations? Those are some of the things to think about. And again, you're tying it back to your strategic plan. You're doing financial modeling on investments that are helping you get to where you want to be 3 to 5 years from now. And that was a lot to go over. Gonna take a break here and open it up for more questions. I'm just taking a look at the chat here. That's right, and got some support on some of the examples. I welcome anyone to unmute it and bring up a question. You know, we went over a lot from statements to KPIs and really focusing on your strategic plan and making investments to get you along those plans. This last slide, I just want to show you, has a lot of resources on some of the things we're going over. A lot of content on there. Check with your medical societies. Reach out to your practice support coaches. You know, we're here for you to provide you some support.
So, Ramin, great examples. Yes. I think they're very helpful and certainly can be applied. I do want to go back to the question I fielded about moving into higher risk arrangements. And one more point to make related to that, as you consider going, you know, taking more risk and going into more of those downside risk, higher risk arrangements. One of the key things that I didn't mention earlier is really not only understanding your internal quality measures and how well you're doing, but you also need to start really understanding the overall cost of care for your patients, especially as you make referrals out to specialists or other services outside your walls. Because when you get into those higher risk arrangements, that's going to be part of the equation, is the total cost of care for your patient population covered by that particular arrangement. So it's a little more complicated than just, you know, understanding how well you're doing internally. It becomes important to really understand the relationships that you have with other providers and specialists and how that impacts the care and the cost for your population that you're covering. So just want to kind of reiterate that as well.
Yeah, well said.
All right, well, if we don't have any questions, I want to thank Mark and Ramin for joining us for part 1 and part 2. I just want to make everybody aware that the slides and the recording will be available when you log into your AHEC account. You just have to select My Course and Events, and then you locate the Lunch and Learn. The slides are actually already there, and then the recording will be up by tomorrow. Thanks, everyone.
Thanks, everybody. Bye.